So, good evening, everyone. We are back with Diabetes Dilemma, and Happy New Year to all of you, and welcome again on this platform of Diabetes Dilemma in 2022. We assure you to continue our interesting scientific sessions on this platform of brainstorming the burning issues, which come across in our day to day practice. And there are some questions, different opinions, and we can discuss with experts. So today's Diabetes Dilemma, as you see, this is our program, and which you will be seeing in our webpage, www.diabetesdilemma.com. If you go scroll down these first initial few lines, you will always see upcoming session, and you can directly link on the upcoming session, and there is a direct live link, as well as you all get emails and the WhatsApps with the live link. If someone wants to watch all recorded previous sessions, then please log in, register, and use your user ID, which we will send you. I think last time we have sent everyone the login ID. And today, whoever is joining you, you will get again the login ID so that you can watch all our recorded programs, which have very, very good scientific material as well as practical discussions. So this is our webpage of www.diabetesdilemma.com. Today, I am happy to introduce Dr. Sujit Chandratriya as an expert. Let me first, I won't say apologize, but I would like to inform everyone that Dr. Avdesh Singh will not be joining today. He is from endocrinologist from Kolkata, but Dr. Avdesh Singh is not well, and he was trying to join at least as an expert for discussion, but that is also in the afternoon. He sent me a message. He's really not well. So thank you, Dr. Avdesh, for informing me, and please quickly get recovered so that you can be here after 15 days for my next session. And I'm extremely delighted and big thank you to Dr. Sujit Chandratriya, who will be joining very shortly. Dr. Sujit Chandratriya is an endocrinologist from North Maharashtra, is practicing in Nasik. He has a very distinctive career in his education. I think right from his MBBS days, he has kept his gold medal till he finished MD. Then also he got a first rank from Mumbai University in DM Endocrinology. He got a first rank again for DNB Endocrinology. He has winner of A.V. Gandhi Gold Medal Award with 1 lakh rupees for the research paper. Lots of scholarships here as well as abroad, and multiple publications in peer-reviewed journals nationally and internationally. So we have this young dynamic endocrinologist, Dr. Sujit Chandratriya, today with me for our Diabetes Dilemma session. So thank you, Dr. Sujit, for joining with me. I will be discussing few aspects of sitagliptin use in our clinical practice. Then we discuss all our important clinic points with Dr. Chandratriya. So today the topic is let's revisit sitagliptin in the era of all the gliptins, mainly the other gliptins, and of course SGLT2 inhibitor. I thank everyone, and I thank particularly Sun Pharma for today's specific Diabetes Dilemma session. So all of us, and please join everyone for the discussion. I think Dr. Sujit is here. Big welcome, Dr.
Yes,
Sujit. Thank you so much because you joined with just...
Yes, absolutely.
So I will be just starting some initial introductory, some 20 minutes, some information just to do some recollect about the sitagliptin. And then I think we discuss about the present points and the important aspects of sitagliptin use. So hello friends, I am Dr. Shailaja Kale from Pune. So everyone is trying hard to get a universal solution for diabetes management, and there are various points. So I have put a question mark, is there a universal solution? I think there is no universal solution, and everything points towards individualization in type 2 diabetes management. You will see a lot of crowded slides like this to see what to use. And when you see crowded slides, that means you have lots of options. And when you have lots of options, what it means, therapy needs to be individualized. Now, this slide says if HbA1c less than 7.5, the latest guidelines, you can use monotherapy. But all of us know, even when A1C is below 7.5 or maybe 7.1 or 6.9, the Verify has shown that DPP-4 inhibitor and metformin combination is very good in such patients with a lower A1C and gives lots of benefit down the lines, 5 years down the line. Plus, according to the comorbidities, we always use combinations. So I think combination is the key. I think combination is the universal solution in type 2 diabetes management. So there are many complexities. All these points we need to manage at one stage, at one point. It's not one after the other. That I will control A1C intensive, then I will think that patient is adherent, then I will look at his heart and the kidneys and the age and everything. It's not like that. So I need to define my A1C target, whatever 6.5 or 7. I want to avoid hypoglycemia. I need weight management. I need that patient should be adherent to whatever I write. At the same time, I need to look at the patient's heart, patient's kidneys, patient's age, and the other things. So all these 5 or 6 or 8 things happen simultaneously when we decide the prescription or the therapy, and that is the most complex part of type 2 diabetes management. Top of that, we have these Indian type 2 diabetic patients where we really see that there is a insulin resistance. At the same time, there is a beta cell dysfunction. So though we have thin fat Indian scenario, we have more beta cell dysfunction. Also, we have a more abdominal adiposity. So these thin fat people are actually having resistance as well as insulin deficiency. At the same time, we are at the more cardiac risk as well as we have more kidney problems in India. So it's truly sense, it's really, it's like walking on a tight rope when we manage type 2 diabetes day to day in our patients. And at every step, combination is the key to success for the patient as well as for a treating doctor. Now, when we see diabetes octet or different, like as DeFronzo has pointed out, that type 2 diabetes is not one defect, but there are multiple defects at the level of beta cells, at the level of alpha cells, at the level of adipose tissue, in the liver, in the brain, everywhere, and also in the muscles. So all these defects are not addressed by one class of agent. That's why, as I said earlier, if you want to address all the defects, again, I want to repeat, combination is the key. But if you look at DPP-4 inhibitor, most of these defects are addressed by DPP-4 inhibitor. So somewhere, if there is a DPP-4 inhibitor in our prescription, it takes care of a lot of things of the defects in type 2 diabetes. Now, these simple and safe drugs are indicated as an initial choice in newly diagnosed. Even when patient has a diabetes of more than 10 years, we all know that incretin-based therapies work very well. And we know that patients do respond to incretin-based therapies like DPP-4 inhibitors even after 10, 15, 20 years duration of diabetes. So not only newly diagnosed, but even patients with long duration of diabetes, these are very useful drugs. If there is a ASCVD, yes, again DPP-4 inhibitors in combinations, because now we want to avoid hypoglycemia. We don't want weight gain. So these are also again preferred choice in combinations. CKD, again a preferred because there is a mild kind of a whole profile of DPP-4 inhibitors we can use in many patients with compromised GFR. Whenever there is a compelling indication to minimize hypoglycemia, this is the first drug of choice. And as I said earlier, A1C more than 7.5 in combination, even below 7.5 in combination, I think these are the class of drugs which we use everywhere, wherever there is a type 2 diabetes patients. So they are right fit every time, so there is a better adherence. As we always discuss about hypoglycemia, cardiac problems, renal problems, intensive A1C, glycemic variability, but everything is going to happen if someone is adherent. So adherence plays a major role for the success in type 2 diabetes, especially in chronic diseases. So gliptins are associated with better treatment maintenance and lower discontinuation compared to other class of drugs. And these are kind of studies one after another, which again say the same thing. And that's what it gets translated in all our prescriptions, which we also face in our practice. Now, we all know DPP-4 inhibitors actually inhibit DPP-4 enzymes, and how much DPP-4 remains, which is uninhibited 24 hours after the single highest approved dose of gliptin. So the lowest, I think the long-acting gliptin like sitagliptin, which shows a better efficacy or kind of a better profile with DPP-4, which is inhibited. Now, a lot of things has been discussed about the selectivity, and I think when these were introduced first so many years, we were discussing about the selectivity. Just to do a recap, we know that there is DPP-4, there are other DPP sites like 8, 9, there is FAP. Everything gets inhibited by DPP-4 inhibitors, and slight differences like some side effects of cold or the skin rashes, they differ among the gliptins according to their selectivity profile. Some issues with saxagliptin, which we know that we faced of the heart failure, where actually it was the selectivity with the which actually matters. In this, sitagliptin shows a kind of a selectivity profile, which actually it is also better for DPP-4 over DPP-8 and 9. So it is kind of a strong effect on DPP-4. Also, many fold increase on DPP-4 over FAP, because again that was actually decided query question mark responsible for those increased heart failure with saxagliptin. So compared to these saxagliptin, sitagliptin shows a better kind of a selectivity. So these kind of a side effect may be thought as less. Now, if you compare the efficacy of sitagliptin compared to other gliptins, we all know that most of the times they all are same. That efficacy profile of all gliptins, overall they are same. There are few head-to-head trials, and there are mostly it is RCTs, randomized controlled trials data, which is pooled. And so you will see all these kind of slides, vildagliptin is better than sitagliptin, sitagliptin is better than vildagliptin or linagliptin, that you will again and again see, but there are very few head-to-head studies, and most of the times I will say all the gliptins are same efficacy-wise whenever we are using in clinical practice for A1C reduction. So again, comparative effectiveness, similar efficacy as a monotherapy or in combination therapy whenever we are using drugs like DPP-4 inhibitors. Sitagliptin has a loads of data because we all know it was introduced as a very robust kind of a DPP-4 inhibitor initially. I remember I started my clinical trials of DPP-4 inhibitor with sitagliptin way back in year 2000. I think we started these studies, and all these DPP-4 in sitagliptin is very robust monotherapy. It is effective in all combinations with all other anti-diabetic agents and shows efficacious decrease in the A1C whenever you add to either thiazolidinediones, mainly pioglitazone, when you add to sulfonylureas, and also when we add it to insulin. Even with the insulin, it shows further reduction in A1C. So sitagliptin is a good molecule as a monotherapy as well as in combinations. So it significantly improved glycemic control and well tolerated in Korean subjects with type 2 diabetes with different background therapy. So this is a large number of patients, thousands of patients. And again, whenever you add a sitagliptin over a baseline therapy, it shows a better results compared to and a better adherence. Now, so one was it's kind of a safe profile. It's a good efficacy, very good in combinations. Now next is comorbidities, because we need to look at the heart and we need to look at the kidney right from day one of diagnosis of type 2 diabetes as well as day one when the patient sits in front of you. So right from the first time we see the patient, these are the two things we need to see. So the meta-analysis includes this 12 randomized trial. Actually, it compares sulfonylureas versus gliptin as expected. The cardiovascular safety profile is better and it favors DPP-4 inhibitors that we all know. But again, just to take a recap, compared to SUs, DPP-4 inhibitors are better. Now, cardiovascular outcome trials became a kind of a mandate after the rosiglitazone big problems, and Steve Nissen came with his paper, and we all know that rosiglitazone was banned, and after that we know CVOTs became mandatory for every new molecule. Actually, if you know the TCOS, which was a kind of a CV safety or CVOT trial, kind of with sitagliptin, was designed before this mandate of US FDA. But all the problems of DPP-4 inhibitors started when SAVOR-TIMI was published, which actually showed that saxagliptin is safe. It doesn't increase the CVOT or the cardiovascular outcome. 3-point MACE and 4-point MACE was same. There was no increased mortality compared to placebo, but there was increased heart failure, and all the discussion around DPP-4 inhibitors started after SAVOR-TIMI. Again and again, lots of analysis happened, and there is still kind of a data which don't know. There was some relief when we saw Carmelina, which was the linagliptin trial, very nicely designed study of DPP-4 inhibitor CVOT, which actually showed that there is no increased number of heart failure in patients who are receiving linagliptin. So we have a robust data of Carmelina, which shows that there may be a class difference, or maybe SAVOR-TIMI design of the trial, the baseline characteristics of the patient, because it was a TIMI group, remember? So the patients were recruited from the cardiology clinic. So the baseline high risk was much more in this SAVOR-TIMI group compared to Carmelina. And if you see TCOS was standard type 2 diabetic clinic patients were recruited. So there may be individual differences between the molecules, or maybe individual differences between the studies. We don't know. But if you think about sitagliptin and linagliptin, these two gliptins, we do have a robust data to say that it doesn't increase heart failure. So these two molecules we have. So the TCOS design, I was a part of TCOS trial. So I know it was like standard our type 2 diabetes patients who come in the OPD, and we manage them in our standard clinics. So the only thing was here, it was very good, was all diabetes duration was almost more than 8 to 10 years. And they had high risk factor. They were not very high risk like EMPA-REG or all, but they have one or more kind of a high risk factors, and a large number of patients, more than 14,000. So where the sitagliptin was compared to over and above the present treatment, and the placebo was given, and we all know it was non-inferior. There was no indication of increase of a CV kind of a risk. So it was quite safe to use sitagliptin in type 2 diabetes patients with more than 10 years of diabetes who have a high cardiovascular risk factors. These were the patient. And in this population, there was no increase in the heart failure admissions for the heart failure hospitalizations. So that was not increase which was seen in TCOS. It was intended to treat analysis in this group of more than 10,000 of patients who use sitagliptin. And we also have a large real world data of sitagliptin from different registries, mainly from US, because this was the first DPP-4 mainly used in US. So there was thousands of patients. The real world also showed that there is no increase in the heart failure hospitalization with sitagliptin. So the TCOS key findings were it was prior to US FDA mandate, consistent with FDA guidance, that is all CVOTs. It was the largest, almost more than 3 years, but the average follow-up of 3 years, then it was stopped. More than 30% of patients from the Asia Pacific, more than 12% from India, as there was many centers like us who participated in TCOS. And good design. It was appreciated for good design, and patients were managed by primary care physicians who were treating it, and it was an addition of sitagliptin. So the CV outcomes from the real world evidence, actually this was a big data from the Taiwan National Health Registry, where actually in the real world settings, wherever there was a sitagliptin use which was compared to non-sitagliptin use, there was a favorable kind of a cardiovascular safety issues, which may be because there are sulfonylureas or other factors, but in the real world studies, many times it is shown that DPP-4 inhibitors and sitagliptin here in this big registry is having a favorable kind of a effect on cardiovascular risk. But in the TCOS, it was safe. So it was not increasing the risk. Now the second big organ, which whenever patient comes, we look at the urine albumin creatinine ratio, patient's creatinine, the last creatinine, the next creatinine, of course, the family history of patients' diabetes with the CKD. So all these factors are crucial when we prescribe the different drugs to these patients. So CKD is quite more number of patients which we see in India. So if you see the TCOS data, there was a large number of patients who had a compromised GFR in these patients. So there was patients with CKD. Almost 23% of participants had a CKD in TCOS because the patients had a duration of diabetes of more than 13 years, and it was expected they will be having some compromised GFR. The treatment with sitagliptin was well tolerated, and there was no differences in the rate of declining in GFR whenever sitagliptin was used, and 3 years was a good kind of a period to know that this drug is creating a harm or no harm. So there was no clinically significant impact on cardiovascular as well as on the GFR or CKD outcome. So because it was a nicely designed study, TCOS, this data is there for a sitagliptin molecule. I will like to mention here again that if you all remember, though SAVOR-TIMI was discussed about heart failure, SAVOR-TIMI was the first trial because of the beautiful design and the good calculation. It was shown in SAVOR-TIMI that DPP-4 inhibitors do better to kidneys over and above the glucose reduction. So whatever effect on the GFR and the proteinuria was seen with saxagliptin in SAVOR-TIMI, actually it was independent of its effect on the A1C. So that was the first time we got a big kind of a data. There were small reports from each and every DPP-4 inhibitor molecule that they decrease proteinuria. We have a sitagliptin, we have a linagliptin, but SAVOR-TIMI was the first trial which actually showed in large number of high CV risk patients, it is showing some benefit to the kidneys. And actually this slide actually shows that there is an effective A1C reduction in patients with chronic kidney disease whenever you use different DPP-4 and also the sitagliptin. So as I was saying, all gliptins and even sitagliptin have a greater reduction of albuminuria compared to sulfonylureans, but they are also independently, they have an effect on proteinuria, and this effect is independent of their effect on the glucose. It is said that there are DPP-4 receptors which are quite expressed in the kidneys itself, and it has a direct effect in the glomeruli and kidney where it actually reduces albuminuria. I think if we remember all the initial effects of DPP-4 inhibitors, you will see decrease in albuminuria, decrease in endothelial dysfunction, decrease in inflammatory markers. All the CV risk factors were reduced whenever you see these 6 months trials, very nicely designed trials with DPP-4 inhibitors. So even sitagliptin reduces proteinuria. There are lots of patients which we see nowadays with liver transplant, which I will like to discuss with Dr. Sujit. But what is the place of DPP-4 inhibitors here? And different OADs in liver disease, there is a limited choice because we don't want any drugs which will produce severe hypoglycemia. And we don't use thiazolidinediones if the liver enzymes are more, and we avoid these drugs. So insulin remains safe, but if you don't want hypoglycemia, DPP-4 inhibitors can be used. And now there are lots of studies coming that actually DPP-4 inhibitors are showing some improvement in the NASH, that is the earlier stages of liver diseases which are present with type 2 diabetes. So non-alcoholic steatohepatitis, there is an improvement with sitagliptin, and there are studies of it. I will also mention here that there are studies with SGLT2 inhibitors as well, presented in this year's ADA, which actually showed biopsy-proven improvement. So whether DPP-4 inhibitors or these new drugs, there's a new kind of indication for SGLT2 inhibitors, they are showing some good effect. Now, when you come to advanced liver disease patients, then one needs to be careful with SGLT2 inhibitors. And because of the safety, DPP-4 inhibitors are kind of a better drug of choice in these patients, especially sitagliptin, because it's excreted from the kidneys. There is we all know these drugs all act from the incretins, and there is a good effect of the incretin hormones GIP and GLP. They even metformin works like that. These incretins actually have an effect on the ghrelin as well as the leptin balance, which regulate appetite from the hypothalamus. And these two hormones have some effect of incretin hormones on that. So this was a study which was actually compared sitagliptin versus medical nutrition therapy in patients, and within 12 weeks actually the ghrelin was reduced. There's lots of research. We know that when you reduce the stomach capacity or take out the stomach, the patients lose weight, and actually even diabetes decreases or mild diabetes disappears in patients of obesity surgeries. This may be effect through the ghrelin as well as all other incretins. But the ghrelin decrease and change in the appetite has been very nicely shown in this 12 weeks trial with the sitagliptin use. Sujit, we will discuss about these few things, even with fasting, what happens to the ghrelin, if you have some comments. So let me go through next 4 or 5 slides, where again the sitagliptin use as an add-on to insulin. We all are using it day, night, every day in so many patients. So as I was saying, gliptin show, like sitagliptin, it showed a good effect on inflammatory cytokines. It shows a good effect on CRP, interleukin 6, IL-6, IL-10, and also it shows a very good effect, or as I was saying, ghrelin as well as leptin values, reduces ghrelin, increases leptin, so that appetite is reduced. And also sitagliptin shows a quite significant effect on endothelial dysfunction. So all the CV risk actually factors are getting reduced. In today's era of COVID-19, where every day we want to write prescription, and we have started getting phone calls now in Pune for last 1 week. Today, I think I got the highest number of calls. I'm waiting for the next week that so-and-so is positive and I need to manage sugars online. And here we know a patient is ill, you can't see the patient. Many times patient can't check their sugars. And most of the times we are dependent on DPP-4 inhibitors, which are generally well tolerated and can be continued in this era of COVID-19 when the patients are not very sick, but kind of a mild and moderate disease. So the key advantages in this new normal era of COVID with gliptins is they are effective, can be combined, it's quite safe, very few drug interactions, and kind of a safety profile which doesn't need much of a monitoring. I think this becomes again drug of choice in the present situation when there are so many COVID patients around us. So the key determinant of choosing is it's very well tolerable, few drug interaction, good efficacy, durability as we know, and of course patient access and availability. Everywhere it is there, and now the cost also. So sitagliptin was used in patients with COVID-19, and there is a kind of a data where it was used. We also know that sitagliptin was used in patient with Ramadan, and there are very good reports that it was effective even with such kind of a long time fasting where patients are on Ramadan. I think sitagliptin was very correctly used, and it's a kind of a DPP-4 inhibitor which has the data in Ramadan, which also reduces glycemic variability. So the key takeaways, I will like to say that even though you can't read because I think it's a small size slide, the letters are small, but let me just say that good adherence, easy kind of a dosing, availability and patient tolerability is quite easy for DPP-4 inhibitors and sitagliptin. Highly selective DPP-4 inhibitor so that it is kind of a more efficacious 24 hours action so that you can give once a day dosing, and that actually reduces number of pills, adherence improves. When it comes to heart and kidney, robust data of sitagliptin which can be used safely even in high risk patient, even with patients with compromised GFR. So I think this was the first gliptin approved by US FDA, and all these are, so all that juggling around, walking on the tight rope becomes easy when we are having molecules like sitagliptin in our basket. So thank you so much. So thank you, Dr. Sujit. So I just finished slides. You are aware that Dr. Can you hear me? I can't hear you.
Yes, ma'am.
Yeah, yes, good. So I think you just finished something and last minute you said yes to us for dilemma. Thank you. So what is your opinion about sitagliptin? And I think we all have used right from the beginning. So
yeah, it was actually a great step in the kind of evolution in the treatment of diabetes, especially OHA. We can remember those era when we had only sulfonylureas and metformin, kind of accidental drugs, really speaking, not designed drugs per se. And definitely the mechanisms of actions were found out. And we got pioglitazone. There was something called benflurex that time with proglitazone, rosiglitazone. So again, kind of accidental drugs. Maybe the advent of spectrometry and the electron microscopy in 1990s actually led us to search and study of these mechanisms. And this was the first really a design drug, truly speaking, that we have examined certain kind of mechanism and how it is affected in the diabetes or diabetogenesis and how to correct that. So that was one of the intellect actually the human being has actually evolved to. And we are very, very happy with that, really speaking. We
okay.
also had, when I started my clinical trial practice in 2005, another molecule by Glenmark that time. It is now 15 years, so we can talk about it now. Otherwise, the confidentiality remains for 15 years. And it was called GRC51. And we had a lot of patients enrolled in that. That was my first clinical trial actually as an independent principal investigator. And we had everybody getting lymphadenopathy, really speaking. So the selectivity of DPP4 actually becomes an important issue there, and we could find out that DPP 8, 9, and 7 were actually cross-reacting with that molecule. Finally, because of those AEs and SAEs, actually, the molecule had to be really discontinued, and we could not complete the trial. Sitagliptin was part of the development program in the beginning, and it was an excellently conducted trial by MSD actually. The trial's name was MK69 in the beginning. And it was a great thing to have, really speaking. The drug was really potent, acted fantastically in a well-defined clinical trial settings. Actually, we were really amazed. We had some reports of pancreatitis and headaches in the beginning, in the early post-marketing surveys. And that pancreatitis kind of debate was actually lingering for a long time. Then it was understood that even a diabetic would have a pancreatitis in much increased incidence per se. And there was no causative role. From that time, the gliptins have really come up a long way, and it has proven the way to other molecules which are designer molecules like GLP-1 receptor agonists and of course SGLT2 inhibitors. And now we know these are the first product choices almost to all the guidelines, really speaking. So this was the first giant leap by mankind, really speaking, in the designer kind of drugs, that you understand the mechanism which is going wrong and try to address that issue by selectively creation of a drug. And that I would consider the greatest kind of the achievement per se. With that, some disappointments also did come. Initially, it was thought that it's a trophic drug. It would act on the pancreatic beta cells and there would be some regeneration of beta cells. Though I was involved in the development program, many of the physicians actually were shown these slides by the investigators in the beginning that this is the pancreas before the treatment, after this is the treatment, after treatment, this is the pancreas, and the beta cell mass did increase. But of course, it all was true in infant rats, really speaking. And that promise was not kept. In the beginning, we were quite actually very, very happy and expecting for such trophic effects of sitagliptin. That unfortunately did not happen so. Though the drug remains excellent with moderate efficacy on the glycemic control, very, very well tolerated, especially in all the other categories like elderly people or comorbidities. And that's one of the fantastic drugs where we don't have to monitor too much, really speaking. So otherwise,
I think I remember what you were saying, Butler's papers about this increased beta cell mass. And I remember there was a debate in ADA. And it was the meeting was I think in San Francisco because he's from California, and then versus that whether it increases beta cell mass or not. That was many years back, and now we all know whenever we say improved beta cell function, most of the times it's glucotoxicity is taken care of.
Absolutely.
And then it improves. Even a simple weight loss will improve the beta cell mass. The apoptosis will go down. So these are the indirect, I think, except GLP-1, we don't know that, which actually even GLP-1 is a bit question mark, but there are some. What is your opinion? Does that actually increase mass or decrease apoptosis?
Again, the final word is maybe we are at the same stage where Sitagliptin showed us those slides, and maybe the time will tell the answer. But of course, for trophic medicine, so if something comes up, that would be really great. So that
Yes.
time we were thinking actually with Sitagliptin that before we get diabetes, we should have something which would increase the beta cell mass. But of course, this drug unfortunately did not do that. But again, it remains an excellent drug, though that part was not taken care of. Again, it remains an excellent drug, and otherwise the acceptability is much improved. Another step which Sitagliptin did was to give a very costly medicine in the Indian market actually. That is a social problem, not strictly a medical problem, but that was the first step where diabetic patients started accepting slightly costlier drugs, really speaking, because we did not have such kind of a costly medicine till that moment actually before Sitagliptin was introduced. And that paved the way for actually the multinationals to enter and expand the markets. So even we would say that unknowingly that is one boon actually, so that the mind gets opened up for slightly costlier drugs if at all we have to get the designer molecules in the future.
So I have to say one thing when we talk about this, cost. I'm not denying the cost-effective drugs improve a lot of adherence and there's lots of benefits. But my personal experience of sitagliptin, and I will say even metformin, though there are no head-to-head trials, but if you really want to see whether this drug is effective, if you take out that drug from the patient's prescription, which happens with metformin many times in our clinical practice, and then you know how the glucoses go haywire, which I have seen by whenever I try to shift patients from sitagliptin to a cheaper DPP4 inhibitor. In few months, I have to go back to the original sitagliptin. In most of the patients, I am not saying every patient, but so it's like so much individualized. We really don't know which works better for which patients. So unless we take the drug out, we don't know how much it is working. That was my experience. So Sujit, there is a question from Dr. Shishir Chodnekar that how does teneligliptin compare with other gliptins?
Yeah, talking on the cost actually came with a bang, really speaking, because it became so cheaper. And in fact, some people were importing from Bangladesh for 75 paisa, really speaking. So we were thinking that next time the Panwala will also start keeping teneligliptin, or maybe every hotel owner in a Srikhand ka dish they'll give teneligliptin. That was that cheap, and the whole mentality got changed, really speaking. So what happened with teneligliptin is that it's a research molecule. We can't deny that. It's not some generic cheap version of a gliptin. It's a research molecule. It's come from Japan. I worked in Japan for some time, and they're known for their immaculate data collection and a fantastic clinical trial settings. I have seen hodgepodge of data in most of the countries, including UK and US, but Japanese people are very good with their data. So whenever a molecule comes from Japan, I usually have some respect for the molecule. Let it be teneligliptin or emogliflozin, though the molecules are not doing that well and are considered as Chinese version of great branded molecules, they are research molecules. We have to accept that the data is much lesser as compared to the established gliptins. There is no question about it. The controversy of STT prolongation for 8 times the therapeutic dose was unnecessarily brought in because no other gliptin has studied with 8 times greater therapeutic doses in any clinical settings. For that matter, any other drug is not done the same, really speaking. So we don't know how much importance we should give there. Those patients who started teneligliptin because they could not afford a costly gliptins responded very well to teneligliptin. There is no question about it. But as Madam has said, even my experience says that some people try to buy a cheaper gliptin, and in many of the times they burn their fingers and they have to go back to the original gliptin. That has seen many times, really speaking. So we don't know that was the kind of a patient phenotype or some kind of maybe different mechanism, but we have seen that time and again. Taken teneligliptin as a standalone case, it has done quite well in India per se. It came with a bang, and it is still one of the commonest prescription going at present, almost trailing by vildagliptin because that is also gone out of patent now.
I think if these cheaper drugs, they come with a bang and there is an initial use. But I always used to say teneligliptin, it's a gliptin and it works. So when the doctors had a confidence that so it works, so Dr. Shishir, I think we all are using. Only thing when there is a patient with lots of comorbidities, and then you don't know because there is no data, and there up till now there was no other gliptin which was cheaper, but now because we have cheap vildagliptin which has some data, so it can be replaced. But yes, many people are using teneligliptin and they are happy with that. So there's, I like to ask you a question about patients with liver transplant because we are seeing, I had a couple of patients and then whenever, can we use sitagliptin in such situation? A patient who has done liver transplant, initial phase is over, about 1 year after liver transplant, patient is absolutely stable, doing everything.
Yeah, we can definitely use that. We have got some data also. In fact, we have data in transplant patients developing diabetes also, the no diet kind of patients also. So in
Yes.
general, we keep it in mind that Sita, Lina or insulin. That's what we talk about such patients actually. And before starting anything else, we are very, 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 very skeptical actually because we don't know how other drugs would act. Vildagliptin with its some notorious data of elevation of liver enzymes, we are actually not on using that. Even some data is there on vildagliptin, but we don't want to, these patients are very, very precious. They are not like garden variant of patients. We get hardly not more than 50 patients in the lifetime of us when we are actually leading them to liver transplant, really speaking. So those patients, you have to be very, very careful. We don't want to tip off to the balance anywhere, really speaking. So sitagliptin very well can be used. Linagliptin also can be used, and otherwise insulin would be the choice, in my opinion, personally.
Yes, and I think in chronic kidney disease also we can use sitagliptin, can be reduced some dose or
yeah, absolutely.
it shows its efficacy.
And we can go to 50 or 25 milligrams also as per the EGFR values. And in fact, before linagliptin came, we were doing it all left, right, center. Because of some actually marketing kind of the strategies of the Boehringer, it happened that CKD actually was equated to some kind of linagliptin usage. But of course, all the gliptins can be used, and there is no question that there is a complete contraindication unless it's a ESRD, of course.
Yes, and now sitagliptin has a TCOS data which shows that it is safe to use in patients with 13 years diabetes duration and a compromised GFR. Now, any a small comment about allogliptin? There is a question from Dr. Pankaj Patwari.
Yeah, there is again a tendency to compare allogliptin with teneligliptin, but these are two very, very different ones because allogliptin is much more studied than teneligliptin, really speaking. We do have a CVOT also. We have got a robust data on liver patients, kidney patients, and even in glycemic control. So allogliptin is one of the excellent drugs. Somehow nobody actually came with the parent company to India, and it was Indian companies with their own marketing strategies. So very good drug, nice drug, and it is not that way actually developed that well in our Indian markets. There is another gliptin called butogliptin, and that was by Phenomics, company called Phenomics from California. One of the best drugs, but they stopped the development because so many gliptins came out. Actually, I was part of study for allo with Takeda Pharma and butogliptin with the Phenomics, and both the drugs actually appeared to be excellent for the clinical usage. But of course, because of the lack of Indian penetration, we don't have hands-on experience with that, really speaking.
Yeah. So Dr. Pankaj Patwari is again asking that can we start gliptin after heart failure, that is post-heart failure? If yes, which one? I will just like to say here, SGLT2 inhibitors are drug of choice and all three are very good in patients with heart failure. About the choice of DPP4 inhibitors, Sujit, you want to say?
Yeah, DPP4 inhibitor after heart failure, if you have to start with, then I would avoid saxagliptin to some extent because we had some data there with some trouble. Of course, it escaped the FDA banning with the 13:9, really speaking. We should know the voting when it was happening in favor of saxa and sitagliptin. 13 people were for and 9 people were against giving the approval because of heart failure. There was a black box warning for a long time, and there still is in certain countries. So we have to be careful. But using sitagliptin or linagliptin, I won't have much of a trouble there. Teneligliptin I would not be using because there is no data per se. Saxagliptin I would avoid with the kind of data with which we have with severity basically.
Yes, so I completely agree with SGLT2 inhibitors on the board. We can use safely sitagliptin or linagliptin, which have a data to use in patients even after heart failure. He is asking, he has saying, Dr. Pankaj, that as gliptins increase sympathetic activity, including heart rate, should we avoid in post heart failure? I think there is some studies of showing are actually GLP-1 analogs, which have shown slight increase in the heart rate. Not up to my knowledge about DPP-4 inhibitors. Actually, GLP-1 analogs have shown slight increase in the heart rate, but again and again, data has shown that there is no kind of ill effects whenever that patients were analyzed who had slight increased heart rate versus patients who didn't have increase in the heart rate. So there was no difference in the outcome in the CVOTs with GLP-1 analogs. Do you know anything about DPP-4 inhibitors, Sujit?
Yeah, there is some very scanty data with the same that sympathetic overdrive can be seen in these patients, but we know that for heart failure, there are four pillars of treatment. One is, of course, S inhibitors or ARBs, second is SGLT2 inhibitors, third is diuretics, fourth is beta blockers. So when we bring beta blockers on the table for most of the heart failure patients, these things actually are taken care of. We have to mind that these are standalone therapies, and a heart failure patient with diabetes is going to be on a polypharmacy in a very bad kind of a way. So the drug interactions we have to come up finally, and we have to see the survival benefit. So these are actually laboratory findings which do not really translate into survival kind of benefit or loss. So we would safely ignore in such kind of situation these actually effects which are theoretically shown when drug is given all alone, really speaking.
So, Dr. Pankaj, I think what Dr. Sujit is, as an expert, is advising, if at all we want to use DPP-4 inhibitors in heart failure with everything on the board, of course, with SGLT2 inhibitor, sitagliptin and linagliptin can be used, and we try to avoid other gliptins because of the scarcity of the data. There is one question which Dr. Oh, so I think he has already answered this question, Dr. Kaushal Kumar, that sitagliptin in modified dose versus linagliptin in patients with CKD, both are same. Sitagliptin has lots of data in patients with CKD, even post-transplant kidney patients, and patients with compromised GFR. You can reduce the dose 25 and 50, and we can safely use sitagliptin in patients with CKD. There is a question Dr. Aman Khan is asking. It's not exactly related to gliptins. What he's asking is, there is a newly diagnosed patient who came to him with complaints of sudden increase in their blood glucose with fasting of 213, but HbA1c was 5.6. So can you comment on such situation?
Yeah, HbA1c is one of the most troubled actually kind of parameter, and same sample in different two labs can have different two reports that we know first of all. So lab error is very, very prevalent in HbA1c. We know that the gold standard is HPLC, high pressure liquid chromatography, and many people still are using column chromatographies if at all they can't afford the 80 lakhs machine of HPLC, really speaking. We also should be doing DCCT standardization of the test, which is not done in many of the laboratories. We have to remember that HbA1c was developed for US population where the laboratory is 50 kilometers away from the home. So the patient goes in the morning, gives the sample for fasting HbA1c, and that was one of the most practical aspects. It's an average, so night sugar is very low, afternoon sugar is very high, we can still get a normal HbA1c technically, theoretically. Secondly, the patient with recent onset high blood sugars is going to have a normal HbA1c because it's an average for 3 months. The RBCs in last 30 days actually would contribute 50% of the HbA1c, and second and third month would be around 20%, 30% approximately respectively. So whenever somebody develops recent diabetes with HbA1c which is considerably normal, it's an indication that it's a recent onset hyperglycemia and not a long-standing diabetes per se, considering that HbA1c is an accurate value. Of course, the lab errors are too many. And finally, what happens in such cases is the treatment decision still remains on the blood sugar levels and not on the HbA1c levels. We can't tell the patient that, okay, your HbA1c is fantastic, you just go home, there is nothing to worry. That cannot, of course, be done if the treatment decisions go on the blood sugar values per se. That's why the new parameters like timing range and the glycemic variability have come. And tomorrow it might happen that they would replace HbA1c completely. That is a possibility in the next 10, 15 years. That is my opinion, of course. Nothing, I would say, scientific about it.
Yes, yes. I think I agree. And with this COVID era, we see some patients on high dose of steroids, which may happen like this. There is a, I won't say 5.7, but kind of a normal A1C range and suddenly high glucose. But it's a wise thing to repeat the test and treat the glucose. And that's what we do. And we always need these glucose readings to manage the medicines of diabetes. So now there is a So yes, I completely agree with Dr. Pankaj that why to choose CETA if we have a kind of a cheaper options, definitely. But always remember it's a different gliptin and it has a robust action. As I said, you can try if your patients are not getting under control with other gliptins. It makes sense not to reduce, not to take out all DPP-4 inhibitors, but you can try a different gliptin and maybe sitagliptin and patient may respond to it. There is a question from Dr. Kaushal Kumar that it's about SGLT2 inhibitors, but it relates to gliptin, so I'm taking this question. Safety profile of SGLT2 inhibitors in diabetics with genitourinary anomaly with acceptable GFR. So maybe some anomaly, but normal GFR. So can we use SGLT2 inhibitor?
If at all the anomaly is not giving more infections, really speaking, so like a reflex or posterior UV baths or something like that,
yeah.
There is no contraindication per se. The literature says that till the time the kidney function is normal and drainage system is not causing any stasis, we can definitely safely use SGLT2 inhibitors. There is another point to it that these drugs are actually improving the survival, kind of the survival longevity of the diabetic patients. So depriving for such causes is also criminal, I would say. Had the drugs been not that effective or not that successful in their data, the SGLT2 inhibitors, we could have withheld them. But now we have two less medications actually, which would actually improve the survival of the patient. So we should give a due kind of the consideration to the drugs. Of course, if we burn our fingers, if there is urinary tract infection, the literature says that if there is once infection, we have to maybe withdraw the drug, treat it, and again after 6 weeks we can reintroduce it. If there is repeated infection, then of course we have to stop it permanently or at least for a long time. Right now, that is what the data says. Again, people have got many practical variations in their own practices, but this is what the literature says. That's what I do follow literature quite strictly because I don't have mind of my own, basically. That's what I believe. And it's best to follow the literature. So I follow this very, very strictly for genitourinary infections per se.
Yes, so I think I completely agree with Dr. Sujit. And yes, so you are talking about some anomalies or non-diabetic kidney disease where there is no increased chance of infection. We can use SGLT2 inhibitor. I think in Credence trial of canagliflozin, polycystic kidneys were one of the kind of exclusion. So the patients with polycystic kidneys were not included, but kidneys with simple renal cysts were there in these trials. So, but infection, yes. Now coming back to fungal infections, there are some studies which show this combination of DPP-4 inhibitors and SGLT2 may be kind of a useful, which reduce the chances of fungal infection. In some of the trials, observations has been there. So I think we have almost discussed a lot of things. Post-heart failure, SGLT2 inhibitors are a must unless it's a contraindicated with very high creatinine, but and it is rising creatinine. So there is no question in heart failure patients. You need to use SGLT2 inhibitors and some DPP-4, as we say. In a newly diagnosed patient, Dr. Parth is asking, I think this is the patients which actually even Verify showed that even with the HbA1c maybe around 7, a combination of DPP-4 and a metformin is a better choice than a metformin alone. And all the patients above 7.5, of course, DPP-4 inhibitor. And so there's just one question Dr. A. Shaha is asking, that what's your take on Vilda-OD? Is it a rational product?
Vilda-OD is a great product actually. And we know that when after Pune actually went to KEM, Mumbai, and the dean of the college and the head of pharmacology department was involved in the sustained release and extended release technologies, and we could actually see the whole efforts taken behind the technology. And it's one of the wonderful things which we could have. Right now, whatever we have, Vilda OD is working quite well. There are PK/PD studies, pharmacokinetic, pharmacodynamic studies, which actually convert the molecule essentially to once a day dosing per se. There is a company which have brought a metformin, which is sustained release along with vildagliptin. Again, a more challenging kind of a task, but they have done it quite well, really speaking. And the concentration remains sustained for over actually 18 to 21 hours, which is quite impressive, I would say.
I agree with you, but my personal opinion is slightly differs here. Vilda OD, there are pharmacokinetics, dynamics, good studies which compare combined offer, but there are very few number of patients. I personally feel whole vildagliptin was good because it was a twice a day. And that's why sitagliptin was introduced twice a day, kind of a, combinations, and we are using. Personally, I feel more the divided doses in type 2 diabetes, it works better, even including glimepiride. So I don't think there is much rational except this competition in the with the longer acting kind of a DPP4 inhibitor to use it as a once a day. That is the only maybe thing, but maybe the number of drugs in the prescription goes down. But if you get a sitagliptin with the same cost of the lower Vilda, I think we will not use vildagliptin OD. We will use sitagliptin. So I think it's just a competition with the price and the market. So anything, just last comment about sitagliptin, Sujit, you want to say, and then I will end the session.
Yeah, of course, we know that it's also going off the patent in next year now. So it would join the list of, Teneli, Aloe and Vilda, and of course, the whole gliptin market would be much more affordable. So this debate of why not use the cheaper gliptin would not come that time. It would be purely merit to merit basis, and that would be the great thing to see, really speaking.
That will answer a lot of questions that why to use sitagliptin, and I think the market will show different kind of results. But absolutely. I think DPP4 inhibitors, great molecules. Quite one thing comes to mind is safety, and we can use it easily. It's giving lots of advantage to our patients. So they are there in our prescriptions for almost every patient, unless they are not tolerated, right? From newly diagnosed to long-standing diabetes, compromised GFR, and even with the ASCVDs. So thank you, Dr. Sujit. I thank Sun Pharma for today's. Thank you for last minute accepting our kind of an invitation to join Diabetes Dilemma.
It was a nice surprise and my pleasure. I'm always eager to come back whenever you call back.
Thank you so much. Thank you, everyone, and all my friends who are actively asking me questions. Thanks a lot. Bye.